Okay, so the age group that we're going to cover at this point is middle childhood through puberty. And just to kind of recognize why this age starts to become unique at this period of development is it seems like at least in the cultures that have been studied, at around the age of 8, we see several transition in a young child's life. Um, for one example is I think I mentioned this, but attachment disorder, if it hasn't been resolved by the age of 8, it then can result in something more serious. In fact, therapists even stop doing attachment therapy at the age of 8 because it's no longer effective, and it starts to then evolve into something called conduct disorder, which is a child version of anti-personality disorder. So, plus, by the age of 8, some of the things that we've recognized that children have experienced is they've experienced loss of some type. And so they're coming to the realization of the world isn't forever and things don't exist forever. And so there's that kind of cognitive maturation that is also going on. So on the socio-emotional end, we see a new phase of emotional development. We see a new phase of cognitive and understanding the way of the world. But it's also around the age of 8 that we start the puberty process. And this can last clear up to about the age of 16. And this is when, at around the age of 8 is when children start getting their secondary sex characteristics. So we'll see that, legs start to lengthen, you start to get breast buds, you start to get hair, and all those kinds of things. So we'll see this as we progress. So that's where we're going for today, is to actually talk about physical development, specifically focusing on puberty. Okay. And the thing that is a kind of a myth about puberty is that people assume that it's like a one night event. You wake up all of a sudden, and for example, if you're a girl, you start your menstrual cycle, and we think that that's okay, that's the end of puberty, or that's the culmination of everything. Or with young boys, we see the same thing. But it's important to recognize that puberty, the actual puberty, lasts about 5-6 years. There's certain things that develop and grow during this period. Okay. Okay. And the things that we should note is that during middle childhood specifically, girls grow much faster at first than boys. Boys will catch up by about the age of 14, 16 or so. But we do see more rapid physical growth among girls than we do boys. And there is this thing called growing pains when young middle childhood children start to expand, especially the trunk and stops to grow as quickly, but what starts to grow the quickest is legs. And you'll notice in late middle childhood and into the tween and teen years, a lot of adolescents will complain about having pain in their legs and those kinds of things. And the majority of it is because of the rapid growth that they're going through. So, and just as I said, the legs grow more rapidly than the trunk or the upper body during this time. And we also see the development of really fine motor skills, which can be seen in children's evolutions of drawings, for example, and their handwriting becomes more refined during this period. They're more able to do fine-tuned things like do 1,000-piece puzzles or models and those kinds of things, and work with fine tools. So these are all things that we see that starts to really ramp up in development around the age of 8. So let's look at the puberty sequence, and there are some things that we do need to qualify. There's been some changes in in this. I think I've mentioned them at the beginning of class. But as I mentioned, for both, for mainly, we see changes started around that age of 8 for both boys and girls, even though, as mentioned, girls start to grow quicker physically than boys. So you'll see women start to go through the puberty sequence at a younger age, where boys will start at around 10 and a half or so. Okay. So what are some things that we start to see around the age of 8 for young girls is breast budding and the growth of pubic hair. And this range of area, these secondary sex characteristics can take anywhere from the age of 8 up to the age of 13, 14 for them to become fully developed. That's why there's a lot, some girls develop younger while some grow later. That's perfectly normal in that period, okay? For young girls, we see the growth spurt again at a younger age than boys. But boys' growth spurts tend to start at around the age of 12 and start to peak at around the age of 13. Where young girls start at around 9.5 and it starts to peak at 11, the full growth. Normally, by the end of these peak periods, the person has their adult height, for example. We do grow a little bit more in kind of into middle adulthood, but then we shrink a little bit after that. But pretty much within inches, your height is set during this period, okay? We see with young girls, the first menstruation is somewhere between the age of 10 to 16. And we will see that there are several environmental reasons that influence this. It's not something that is necessarily biologically set. And I have mentioned that we are seeing this trending downwards here in the United States. I think I'm hoping I'm talking with the right class. We've seen the youngest girl menstruate at around, I believe it was the age of 4 or 5. The youngest pregnant sexual assault victim that I worked with was she got pregnant by her father at the age of 8 and had a baby at the age of 9. So we're seeing this trend downwards, and we'll talk a little bit more about why we're seeing this. And we're seeing the same trends with young boys as well. And so we'll talk a little bit about this as we move forward. But menstruation and length of penis is kind of the determinants that we see with menstruation versus what boys go through during this period, okay? We see that, again, a little bit earlier, girls, I should say, have a change in body shape, growth of underarm hair at a younger age than boys by about a year and a half. And we can see young boys start to have those features at around the age of 13, okay? And so these are the kind of major things that we see as a sequence of becoming what you would consider a physical adult. Okay, this doesn't necessarily mean they have the psychological or social capacities of adults, but by the end of this process is when the young person has their adult physical body. And you can see that they vary based on whether a boy or girl and the like, okay? So as kind of a interesting period, the peak of growth for girls is around 10.5. For boys, it's around 14.5. And it's important to note this myelination thing, because this is kind of some interesting things that we have found over the last couple of decades is we've assumed that the reason some teens have a very difficult time during this period was because of hormones, testosterone, estrogen, and all those things start surging through the body. This is what's going to eventually create the menstrual cycle in the female. It's what starts the growth of the testes and the penis and the boy, and starts to give live, viable sperm. Okay. And so those rush of hormones, it was assumed, makes them a little bit, some make them a little bit more, have difficult adolescence. And the first thing that I do want to state is the assumption that adolescence is hard for all adolescents is actually a cultural myth. We actually find that most adolescents actually make it through puberty with very minor scrapes and bumps. The idea that this is a period of turmoil tends to be kind of a social myth. There are those adolescents that do, and they get, you know, kind of the bad rep of being a stereotype for adolescents. But what do we see that does really affect the decision-making ability of these young growing soon-to-be adults? And that's this myelination. We find that there's about a 6 to 12-month period during the puberty process, usually during this peak period, where the individual's brain goes from very little myelination to almost complete myelination. And this very rapid period of myelination means that you know, the child's brain is going 10 miles per hour, and within 6 to 12 months it's going 2,000 miles an hour. And I think I've mentioned this in the class, so I'll try to keep this a short narrative. This is why a lot of adolescents, when you ask them, why did you do that? And they say, I don't know, they're probably telling you the truth, because their cognition hasn't caught up with the rate of neural firing that is going on in the brain. And so we'll talk about that when we get to parenting and social interaction and what that means for these young adults, or these young developing adults, when we get there. Okay. Growth continues. As has been mentioned before, the frontal lobe is what's going to develop last. It kind of develops from the back to the front. So it usually is, you know, we get the corpus callosum, which deals with our coordination, those fine motor skills that develops. Our parietal lobe then continues and completes its development through this period to where we have good spatial and time understanding. And then there's debate on when the frontal lobe becomes fully developed. I've seen some research that says 20, other research has said 27. But the point being is it's that frontal lobe area, that cognitive area, that higher thinking area of the brain is what's going to develop kind of last, mainly because it's one of the newer areas of the brain. And then the other thing that we do tend to see is adolescents start to, middle childhood and adolescents start to have better memories. Because the connections related to long-term memories are being strengthened rapidly during this period. And so access to memories becomes easier and easier. So it allows them to remember much faster and much easier, because those connections are growing much quicker by this period. I do want to talk about, so we've mentioned some of the issues dealing with physical development in early childhood when we talked about abuse and neglect. I want to focus on disorders during this period, because this tends to be the time period in which most developmental disorders tend to be at least diagnosed, and treatment is usually provided during this period. Okay. Probably the two more common ones that are identified during this period is dyslexia. This is a problem with word recognition and decoding and spelling. A lot to talk about how they see words more backwards or not in sequence. There's reading through the page problems where they often will skip areas and whatnot. And what we found that is associated with this is low levels of glutamate, which has to do with memory and choline. Those all deal with those areas of the brain. Okay. We find in these individuals there tends to be more right hemisphere activity, and the problem with that is it's the Broca's area and Wernicke areas are more like located in the left hemisphere of the brain, and so that lowered activity results in this. The Broca's area deals with understanding words. Wernicke's area is a problem. If there's damage to that area, has a problem with producing words or saying things that they meant to say. Okay. And so we find that's a common disorder that is common, one of the more common ones during this period. And then probably the one that everyone has heard about or has someone in their family who has it is ADHD, or attention deficit hyperactivity disorder. And there's always this debate: is this a true physical disorder? And this argument comes from cross-cultural studies. For example, when we look at comparable countries to ours, such as France, their diagnosis rate of ADHD is under 2%, where ours is somewhere around 13%. And what we find is that it's because in that country, before they'll diagnose the child, they will actually work with the family first and see what's going on with parenting, family interaction, and all of those types of things. And they find, at least there, that by focusing on the family and the family dynamics and the parents, those ADHD symptoms tend to abate. And we can also see in other countries, such as Japan, there wasn't really a known case of ADHD until about the 1990s, when Japan were sending their youth over here to attend American universities. And of course, the big topic for doctoral dissertations during that time was ADHD. So then they'd go back to Japan and they couldn't find any cases of ADHD. And so, of course, they had to create those cases, as the literature suggests, that they had to tell parents to look for these things in their child. And if they do, they need to go see the expert. So cross-culturally, there has been some debate that if it's a true physical disorder, why don't we see the similar rates across cultures, especially when we compare cultures that are similar in dynamics and social dynamics, social economic dynamics, and all of those kinds of things. But there are some potential other physical things. So, for example, we do find that brains of hyperactivities tend to be 5% smaller. However, the problem with this is if you look at the corpus callosum, for example, it's much smaller in women than men, but it's also much smaller between people who don't have schizophrenia and do have schizophrenia. And so are all women schizophrenic because they have a smaller corpus callosum? Obviously not. I only bring up that example because brain size doesn't really tell us much, but we do find this as a consistent thing across samples. Possible cause by maternal use of alcohol and tobacco. That's a very common thing for a lot of children who have especially severe ADHD. We got to remember that ADHD is now on a spectrum, much like autism, where we see the mild symptomology to severe symptomology. And we tend to find that children with severe symptomology, these kind of were predictable variables. Not all of them, you can't say all, but this was a common predictor of those children. Okay. Um, and the question becomes treatment in medication or behavioral techniques. What's the best thing to do? Medicate the child or give them some skill development, some behavioral therapies, those kinds of things. And what the research shows now is that actually a combination of both of those things are the most effective way to treat ADHD and dyslexia. That just putting a child on medication, it cannot provide a long-term solution. In fact, what they find is that just medication, you have to continually increase the dosage, where if you put behavioral therapy techniques into place, eventually you'll get to a level of medication that the child will no longer need a higher dosage as they move along through their development. So, and then there's a growing question about what about intellectual disorders. So this is when a child has lower than average intelligence levels. This is children who have neurological problems. Autism still kind of fits in this, but it's kind of in its own category as well. And what we find is that most intellectual disorders are actually identified in early childhood. And the difficult about treating intellectual disorders by the time it gets to middle childhood is it becomes very difficult to treat. And so the reason why I have a question mark here is the younger we catch an intellectual disorder, the more treatable that disorder becomes. By about middle childhood going into late, it's going to be more of a struggle for that child to overcome or cope with their disorder. So, and then of course areas of concern that we start to look at, especially into middle childhood and going into puberty. And these things are important because the body is going through so many physical changes that it's important to have certain things in their diet to keep up with their physical growth. So what we have seen is excessive calories from sodium and saturated fats. And this probably isn't surprising given the American diet. But we do find that these excessive calories also affect healthy development through puberty. Okay. We find that tends to be an inadequate nutrient dense high fiber foods such as whole fruits, dark greens, yellow vegetables. And again, these have to do a lot with the growth and the development in muscles. Oftentimes when a child has severe growing pains, your doctor will prescribe a nutrient dense high fiber diet and will include vitamins A, C, E, magnesium, and phosphorus as supplements because those tend to then relieve the pain because the body has the sufficient nutrients to help the child grow in a healthy way. Okay. There has been a lot of questions. Is fast food the main culprit of our diet issues of excessive calories, sodium, and saturated fat? And the question is yes, there is the question is yes and no. We find that as the fast food intake increases things, some of the disorders that we're going to look at next, like diabetes and obesity and all those, there's that correlation between the two. But the other things that we have started to see, which also are affecting the increase of excessive calories and everything we've seen, is less and less children are having a breakfast of some type. Because and the reason behind one of the reasons that adolescents especially and middle childhood need breakfast is that gets the metabolism system going. It kind of gives it a kickstart so that the body starts using energy appropriately. And then the other thing that we have seen over especially the last few decades is School lunches are not much more healthy than McDonald's or a Pizza Hut. We're finding that the nutritional value in most school lunches are not much better than as I said, McDonald's or KFC or places like that. So that's another area that we are seeing that kind of contributes to the excessive calories and the inadequate nutrient dense food that children and adolescents need. So from that, these are some of the very common things. We're seeing a exponential rate in type 2 diabetes. Type 2 diabetes, its main culprit is lifestyle and eating and exercise. We see that asthma too, and when I say these are risks, I'm saying what these are we see these continually increase year after year. All right. And so none of these have plateaued. We see that each year there's more emergency room trips due to use of some medication that the child is on or misuse of some medication. And we see blood pressure every year, cholesterol every year, and the likelihood of cancer every year tends to be going up and up and up. And we don't see any of these things plateauing. And so there has been some debate. How do you control childhood obesity? Some have said, well, let's limit TV time, or what we would call screen time today. I think I need to change that screen time because TV is kind of getting to be an old term for us old people. We do see, though, that activity level among children tend to be on the decrease. And what I mean by activity level is children who go outside and play after school, who spend time during recesses being active in the playground and all those things. We're seeing that children are tending to be less and less active. And one of the other questions is, well, what about exposure to commercials for unhealthy foods? And again, studies have shown that when a parent does limit exposure to these types of commercials, children tend to make healthier choices as long as the family provides those healthy choices for the child. So the other thing that needs to happen during this age period is sleep time needs to increase. In fact, right now, when we're talking middle childhood, the recommendation is 9 to 10 hours. When we get to 11, 12, it should bump up to 10 to 12 hours. And there's some research that suggests the high school years really should be getting at least 13 hours of sleep. And if you remember those charts we just looked at, and see the things that the body is going through during these different time periods, it kind of explains why that sleep is, because it's during sleep that our brain is growing, we're creating memories. This is when physical growth happens. This is where the body develops. Our body does not develop during our waking hours. It develops during our sleeping hours. And so, but what we see is that, unfortunately, what we're seeing as a trend, again, just like the risk factors before, is as a child gets older, they tend to sleep less and less and less. So, and part of this is kind of the family dynamics, cultural dynamics, and the like. So when your child is in early childhood, you might put them to bed at 7. And then when they get to middle childhood, it might be 8 to 9. And then by late childhood, you might just say, okay, they can stay up till 10. And what we're doing is, instead of increasing the amount of sleep that children need, we're decreasing that amount of sleep. And then we find it too that the night times are much more stimulating in our modern world. So we see children having screen time later and later and later. So their brain is staying staying stimulated. Lighting in houses, lighting from screens continues that stimulation. And this tends then to contribute to how a child is able to fall asleep in the first place. How do you know if your child in middle childhood is not getting enough sleep? Well, this tends to be the results of lack of sleep. Somatic complaints, so that is physical pain that can't necessarily be explained by some physical trauma of some type. So it's feeling pain in the knee, but there's no actual injury to the knee, as an example. Poor school performance. So school performance goes down. We find that that's associated with lack of sleep. Mood disorder type stuff, such as depression and anxiety. Motor skills, the ability to perform motorly appropriately. And then we also see behavioral problems associated with lack of sleep. And I'm going to come back to this one. So I do just want to mention some of the things that have been talked about.
How many is that?
One.
About as far as physical activity. So we've seen some governmental interventions try to be put in place to increase children's physical levels. So probably the most famous program is physical education, or PE classes. The goal of this was to develop interest in activities children can pursue throughout their lifetime. But physical education classes are actually only required by about 5 states in the United States. It's only part of the required curriculum for about 5 states. And a lot of this has to do with children's attitudes toward PE. They tend to become more negative over time. And so a lot of education systems, due to parent-led initiatives and stuff, tend to weed out physical education because they feel it's having a negative effect on their child's well-being. Okay. And there is a theory that supports physical education classes. It's called leisure repertoire theory. And it tries to teach that in leisure, it's more healthy to be active and physical than it is to be sedentary and non-physical. And this theory has kind of shown that if a child is encouraged to be physical during leisure, they're more likely to live a physical lifestyle. And that's kind of the kind of basis for physical education. In some places it's had success, and others it hasn't. And then of course there's always the negative view, especially as a child starts to go through puberty. They start comparing their bodies with other people. They see others are growing faster than they are, and this whole social comparison component of physical education really hasn't been worked out that well. The one thing that we have shown is that recesses, in fact, the American Academy of Pediatrics says recess is a crucial and necessary component of a child's development. Okay. Interesting, in the US, the recess counts for about 40% of a child's daily activity. And schools can provide children with very inexpensive equipment and promote activity. Promotes classroom attentive, social skills, skills of development, self-control. And I'll say there's some really interesting studies that have come out where there's schools who are reduced their recess time, and then there's schools who have increased their recess time. In the schools that reduce their recess time, so they go from like an hour to half an hour a day, they actually see a significant decline in classroom performance, doing assignments, doing well on assignments and all those things. Those schools who increase their recess time, so they go from an hour to 2 hours, for example, they see an increase in the child's academic performance. So the idea that academic performance is only something that occurs in the classroom is kind of a myth. And what the science shows is that we really should be getting our kids outside, into recess, into that active play, and not be decreasing that amount of time. At least that's what the good science says. I'm going to skip this one. What I want to do is just kind of talk about the impact of active play, which involves recess, and all of those things. And I just want to show some of the impacts that as we increase active play, and this is middle childhood, even into adolescence, we find this is associated with less obesity, greater ability to focus, better self-discipline, lower levels of distress, higher self-worth, and positive and protective attitudes towards the natural world, especially when that active play takes place outside. And I think this previous slide kind of mentions this. We have found that there's a positive influence on outdoor play. Okay, we found that let me make sure I have this right, is that we have found that it actually increases their performance. It's outdoor play is predictive of all of these things, plus whatever active play also is included. Okay, so there's something about having children in nature that increases their emotional and cognitive abilities as well. Okay, that is all we have to present on physical growth. So I'm going to stop